today. For those students who, well, after the seminar, there is food upstairs. For those of you who might be in EOHS 402, please, stay here, do your thing. It's okay if you wander in late to 402 today, if you want food. But thank you again for coming today. Thank you for Dr. Cohen, who is a member and director of our minor center here at UIC. He really has put us, and the entire minor center group has put our group on the map for the impressive work that they do. So we're happy to see all of you here. And I'm going to let you introduce yourselves. So thank you again to everyone.
That works for me. So today, thanks for coming. And we can all make a mad rush for the food afterwards. Beat me there. Today, what I'm just going to try to do is give you a little bit of a potpourri of what we do in the minor center, a little history of how we got to be a minor center in Chicago, where there's relatively little mining in Chicago. I think there's a museum in the basement of the Science and Industry, but we'll talk a little bit about how that happened. And then some of the different research projects that we do, and a little bit of about the international work that we've done as well. And my colleague Leonard Go, wave your hand, Leonard, is in the back, who has participated in a lot of this work and is here to also make sure I don't make any mistakes and to answer questions as well. So let's see if I can get this thing to work. Okay, these are our sources of funding. We are not conflicted at all by any of this. So our Mining Education and Research Center was founded in 2018, but a lot of our work in coal miners' lung diseases and black lung and other things began decades earlier. Our mission in the Minor Center is to provide clinical work, take care of these guys, these miners that come and they see us at our clinic, which is actually at Northwestern downtown. We do a lot of work in education and training of physicians and other folks that care for people that have mineral dust lung diseases. And we do expert consultation for various government agencies and work elsewhere. And also we are engaged in a lot of research. So we hope that a lot of our teaching and training and education gives us access to wonderful data sets that we can then publish on. And this is a lot of our folks in the UIC Minor Center team. Kirsten Omberg, she here? Yeah. Hey, right on cue. There's Kirsten, who will be speaking to you in a little bit later this year, I think, in another cafe. We already introduced Leonard. Lee Friedman is another great colleague. Yuan Chao is here, as well as Dolores and Rocio and many of our other staff that, and Kathleen Kennedy and Rocio, who are part of our group as well. So the whole program for taking care of coal miners and a lot of this massive national program only really resulted from disaster. And there's the main disaster that led to this, and actually led to NIOSH and led to a number of other government agencies, was Farmington, West Virginia, that exploded in 1968. And Consol mine number 9 blew up and killed 78 miners. And it actually resulted in a huge movement of coal miners that were demonstrating to have better conditions for miners. But interestingly, it was one of the first strikes that was ever held for a disease, or where miners were not just fighting for wages and improved working conditions, but they were fighting to get some kind of recognition and compensation for a disease that really wasn't taken care of. So it was a very interesting thing in that respect. It resulted in these mandatory health and safety standards, the Coal Mine Health and Safety Act of 1969. It created the Mine Safety Health Administration. It created the Coal Workers Health Surveillance Program, which is run by NIOSH out of the Respiratory Health Division in Morgantown, West Virginia. It also created the Black Lung Benefits Program, a federal compensation program. Any worker that's a coal miner throughout the whole country can apply to this program and get diagnosed and get treatment and get rehabilitation services. And it's one of the few things where workers in an industry anywhere, everything else is state-based workers' comp. And they say if you know one state-based workers' comp program, you know one state-based workers' comp program, because they're all different and they all don't do the same thing and they don't work as well. But this federal program is sort of unique in that respect. And the goal of these legislation at that time was to reduce the risk of pneumoconiosis and, of course, taking care of folks that have black lung. And it was really a big movement. They shut down West Virginia. These guys marched and on Washington, D.C. Richard Nixon was in office at the time, and he actually signed this legislation. So it was a pretty big movement. It resulted in this act that mandated limits and for dust and making sure that folks didn't get respiratory disease. And it was amended in 1977, and they said that no minor should ever suffer material impairment of health or functional capacity if they're doing their regular job. In other words, you should be able to go to work for your career and come out kind of okay. And they were trying to pass laws and regulations that would really help make that happen on a national level. And it didn't happen because of nice politicians. It happened because these guys threw down their tools and they marched and they fought, and actually there were a few nice doctors that helped them, but it wasn't nice doctors that did it. It was really the workers really fighting for it themselves. So Black lung disease is a nice paradigm for understanding primary, secondary, and tertiary prevention, which I'm sure you've all learned about. That legislation put into effect permissible exposure limits for coal dust for the first time. And that's primary prevention. You reduce or you get rid of the exposure, you prevent the disease from ever happening. And we've played a role in that in our group in testifying before Congress to improve those regulations. And in particular, we've been working a lot on silica exposure, quartz exposure in the mines and in our country. We've been working on that. The next layer of prevention is secondary prevention, where you screen populations of people that are at risk and you try to identify early disease. And if you can identify early disease, you can mitigate their exposures or remove them from exposures and try to prevent the disease from progressing. We're very heavily involved in this work. NIOSH has a program called the Coal Workers Health Surveillance Program, where they mainly took x-rays for many years. And in recent decades, they've added spirometry or lung function to screen people for early signs of Black lung disease, this horrible disease that you get from inhaling respirable coal mine dust over your lifetime. And we've been doing a lot of work in this, not only in the United States, but also in other countries. And we'll mention a little bit about that. And finally, tertiary prevention is really healthcare, treating people that are already sick. So if you have a disease and you go to the hospital and you get therapy for it or you get rehabilitation for it, that's tertiary prevention. And we're actually very heavily involved in that as well with our Black Lung Clinics program, which we'll talk about, where we diagnose, treat, and provide rehabilitation services for coal miners. We also help them get compensation. We help them with their paperwork and their claims and this rather adversarial process to get benefits. So I'll talk about the tertiary prevention, and then we'll go a little bit further back up the scale to primary prevention. So our Black Lung Clinics program, there's 15 grantees in 11 states, and I've listed the states there, and a number of these states have several sites throughout their states. A lot of these are based in Appalachia, Central Appalachia, which is Kentucky, West Virginia, and Virginia. And they've got lots of little sites, little clinics in very rural and somewhat poor areas of the country. Our program here, you might wonder how it ever happened, but the first clinic programs were funded right after that 1977 Federal Act in 1978. And back in the 70s in uptown Chicago, there was a huge population of displaced workers from Appalachia who come up here to get industrial jobs. And uptown had actually bluegrass bars and they called it Little Appalachia. And Cook County Hospital, along with the Uptown People's Law Office, wrote a grant, and they actually got funded to have a Black lung clinic to take care of that population in Chicago. But by the late 80s and 90s, that population pretty much had been working through their benefits. They weren't any new miners coming from that region to Chicago. And so we became, at that time, a tertiary center, tertiary care, where we got referred miners from all over the country to get evaluated and treated and help them with their benefits. And that was over at Cook County Hospital, now called Stroger Hospital. You've probably seen it across the street over there. And we had that program, and I directed it starting in '93. And we really became kind of a central referral center. And then in 2013, we moved the program here to UIC from Cook County Hospital. And currently, the form of our program, it's a UIC grant, and we see patients. Our main administrative and management work is done here through UIC, and we contract out at Northwestern, where Leonard and I see patients. And we also work in Southern Illinois and Indiana with FQHC down there called Shawnee Health Services, and the Southern Illinois Respiratory Disease Program there. And we see miners there. We help them with their diagnosis and treatment, and we also fight hard for them to get benefits if they qualify. Well, back in 2014, we applied for and became the first federally funded center of excellence for Black lung in the country. And we've been collaborating with our colleagues at National Jewish Health in Denver to do this, where we provided training and expert consultation and protocols for the clinics all over the country. And we developed a bunch of training modules in education. We developed a web-based data entry program. Kirsten Omberg is our co-PI on this program and has really worked very hard in developing a program where for the first time in history, this program started in '78, we're collecting data on a national level on every individual patient that comes into that program. So not only are we able to just monitor how these programs are doing in terms of providing the services the government pays them to provide, but we are actually now able to analyze it, look at the disease, look at the patterns of disease in our country. And that was never possible until we actually were pushed for that and made that happen. And in 2020, it became the Black Lung Data Resource Center, but it's pretty much the same thing. I don't know why HRSA changes the names of things, but they do. And so right now, these are the little locations of all of our clinics throughout the country, and we do those things that I mentioned in providing technical expertise and resources and really collecting data on this population nationally. So what that's enabled us to do, and what we have done in terms of our research portfolio, is looking at all these people that work with this population, the Mine Safety Health Administration, the NIOSH Co-workers Health Surveillance Program, Illinois Workers' Comp programs, and look at those data sets, which are all done for specific administrative purposes, and link them together and see if we can use them for public health purposes. And we first did this in 2014, where we were funded to link all these data sets together and see what we could learn, because some of them have only active miners, some have former miners, retired miners, and we're able to link that together and analyze it and understand much more about what's happening with this disease, and understand also these programs and what some of their limitations are. So we'll talk about some of those linkage projects and some of the research that we've done, where we linked all these different data sets, and we'll also understand a little bit more about injury and illness. This is something that Lee Friedman has brought to our group. We're just respiratory lung doctors, but we found out that people get hurt in these mines, and we wanted to understand a lot more about how they were injured, why they were injured. And we realized that unsafe mines are also sick mines. So we've been studying a lot about the relationship between injury and illness in mines. And amazingly, there's a correlation. Lee's got a paper that we just submitted that I think is accepted-ish or revised, or any day we'll get a decision. So we'll be letting you all know about that by email shortly. And anyway, we'll talk about that, and we'll also talk about our passion, of course, is respiratory disease. That the lung is the most important organ in the body. So we will talk about all that we've learned about respiratory disease in these folks, physiology studies and pathology studies, and then maybe just mention some of the things that are coming up. So this is a paper that Kirsten led, where we linked compensation and health surveillance data sets. NIOSH surveys healthy, active working miners, and then compensation data sets are there to provide people that are applying for benefits. We wanted to see what was happening. Are people actually participating in surveillance while they're working, or do they just show up at the end of their career applying for benefits when they're already sick? And we found that no one has ever done this before, by the way. No one ever had access to these compensation Department of Labor data sets and access also to the surveillance data sets. It helps that Kirsten and I both work for NIOSH also, so we have access to the federal stuff, but as UIC folks, we can also work outside of the federal government. And we found out that 38% of the mine, or almost 40% of the miners that were applying for Black Lung at the end of their careers had never participated in surveillance. So you have this wonderful program where you go out and you x-ray people and you take lung function studies to see if they have early disease so that you can help them and get them away from exposure, but many people didn't participate. And the problems were, which is a huge, and it was interesting that it varied from state to state. States that were perhaps in some ways more conservative and had very difficult workers' comp programs, people didn't participate as much as opposed to some other states. And it was a huge missed opportunity for secondary prevention. Essentially, what we think is that the miners were afraid. They were afraid of retribution if they participated in surveillance. And in many ways, they're afraid of being sick, of being told that they have early disease and then not being able to work in these relatively well-paid jobs in very poor areas. So where the alternative is coal mining versus Walmart or McDonald's or something. So we were able to, and that has a big impact on NIOSH. They are now going out and trying to figure out ways that they can improve participation in their surveillance. I talked about this Black Lung Data and Resource Center. For the first time, we were able to publish data on this population of coal miners nationally by looking at their lung function in our Black lung data sets. And so Leonard was the lead author on this, and we looked at the prevalence and severity of abnormal lung function in US coal miners. And these are mostly former miners because those are the folks that are coming to Black lung clinics and applying for benefits. And we were able to use all these medical services like chest radiographs, lung function testing, and advanced physiology testing that's done for benefits, but actually try to understand the health of the population. And it was interesting that a lot of these miners had never been studied before, and their information was not part of any data sets that are out there by NIOSH or others. And we found out that a huge percentage of these folks have abnormal lung function. 45% had an abnormal FEV1, which is the main measure of lung function, how much air you can blow out in 1 second. And that correlates with your mortality, it correlates with your ability to work. And so it's a very large percentage of folks that were significantly impaired. 35% had moderate to severe impairment, and they had different patterns of impairment, whether it was obstructive lung disease or restrictive lung disease. These are different patterns that people get depending on whether they get scarring lung diseases or whether they get diseases that are obstructive, like emphysema or chronic bronchitis. And so we just found that it was really important to be able to analyze the patterns and prevalence of disease in this population. And one interesting point here was that 12% of people who never smoked had obstructive lung disease. And it's an interesting thing that many people don't realize, that these dust diseases and various other occupational exposures cause chronic obstructive lung disease, cause emphysema and chronic bronchitis, where everyone just thinks it's all smoking. And so many workers, their occupational component of their lung disease isn't recognized, they're not compensated because people just blame it on smoking. And I think that that's really an important thing that we've studied quite a bit, and we've tried to change regulations and compensation to take that into account. Kirsten we just had this paper published, which I think is one of the most exciting papers that's coming from our group, and hopefully we'll apply for her to get an award for it next year. But no one has ever looked at a population of coal miners' mortality in any large studies. There have been small groups of miners, but I saw a few thousand, where they would follow them and look at their mortality and what they died from. But what we thought to do in our group was to link our data set of anyone who ever applied for Black lung benefits, anyone who ever participated in surveillance while they were working, and put their data through the National Death Index and get their death certificate data, look at their cause of death, either their main cause of death or underlying cause of death, and see what they died of. Because prior to that, all we had is, if someone happened to think of Black lung on their, and put it on their death certificate, we could count that up, or we could look at those very small studies. So we were actually able to get this data, which had social security numbers. So getting social security numbers from the government was kind of a thing, and then being able to submit it and link it and get the results of this. And we wanted to understand what were these folks dying of, and in particular, we wanted to look at folks in Central Appalachia, which is some of the toughest coal mining conditions in the country. And so what we found in this study, linking these important data sets, I don't think I have it in this slide, but there's 250,000 or 260,000 people that we had death certificate data on. That's a fairly large population. And it's really hard to find any other industry nationally where you have the social security numbers of everybody, say, who is a professor of public health, and see what we die of. You can't do that because there is no data set. But this is a national data set of a huge proportion of people that ever worked as a coal miner, so that we could find out what they died of. And this just was published this year. And we found that US miners experience excess mortality, certainly from pneumoconiosis, because that's a very occupation specific thing. And the general population doesn't die of pneumoconiosis very much. But they had chronic lower respiratory disease. That means COPD, emphysema, chronic bronchitis. They died at a much greater rate than the general US population. And there's more lung cancer, which is very interesting as well. And these things have been getting worse. Which is not what you want to see. When you have an occupation, an occupational exposure, and you have a system in effect that's supposed to prevent disease, you don't want to see that the newer cohorts, the more recent cohorts of people that are born and working in this industry, are dying more from an occupational disease than those that came before them. And that was striking for us, because we all want to think that history is moving forward, that we're protecting people more and that we're doing better. But in this particular population, we don't seem to be doing as well. And we think that that reflects these increased rates of disease in these poorer areas of the country that have pretty horrendous conditions, and where actually conditions for miners are probably worse in some ways because of modern mechanical equipment that can chew up and pulverize and produce dust at a much greater quantity than the old days when people used hand drills and blew up with dynamite. So they're getting more coal, but they're also getting more dust and more exposure, and they're getting sicker. And we didn't have accurate smoking data, but we saw that heart disease and other indices of disease caused by smoking were going down in this population. So we think that there's a pretty good evidence that this is an occupational cause. And one of the other things that we saw is that these changes were even worse in central Appalachia, this area of the country where we're seeing a lot of very severe disease. So I think this is an important study and will probably be quite impactful going forward. Well, I mentioned that we had expanded our work, especially with Lee's help and guidance, to look at injury and illness in miners. I just wanted to have you understand a little bit of the breadth of work that we've done in that area. And the Miner Center really has gone beyond respiratory disease and included injury and illness. And now we're actually going to be looking at mental health in this population. So I'm just going to show you a number of these papers that Lee has really mentored people. We looked at injury and illness data from the Illinois industry, looking at Illinois workers' comp data and the patterns of disease there. We were able to get from the U.S. Mine Safety and Health Administration their reports of injuries and illness. It's called Part 50. It's similar to the OSHA's reporting system. When people develop disease or injuries, it has to be reported. So we got that data for the entire country, and we saw, when we compared it to at least Illinois data, that is poorly reported for, especially for illness. There's a massive amount of underreporting by employers. They're not following the mandated federal requirements to report the injuries and illness in their workforce. And because they later applied for Illinois workers' comp, and we could match them through a very complex and wonderful matching technique that I cannot explain, but Lee and Kirsten could, we were able to see how much underreporting there was. And the federal government was actually very interested in trying to beef up their Part 50 program. And this became impactful when the Mine Safety Health Administration was trying to figure out how they could improve that reporting. Then the other thing that we decided to do was to look at, when do people get injured and how do they get injured? Because that data also existed in the Part 50 program. So we could see that when people first get to work, or they have long working hours or working a lot of overtime, there were more injuries in those populations that were working much, a lot of overtime. We all know how well we function when we're doing all-nighters and trying to finish our papers, and you wake up the next day and read what you wrote, and it's not very good. Well, the same thing happens to people that are trying to perform complex manual labor or operating machines, that things happen when they work long hours. And so this was important, again, trying to inform the industry of ways that they could perhaps prevent these things. And I mentioned the first hour of work. It was interesting that there were more injuries in the first hour of work. People get to work, they're sort of a little disoriented. Maybe they're still sleepy, hungover. I don't know exactly what the reasons are, but people had more injuries during this first hour. And that may also indicate that people should have some sort of an orientation, settling in, signing in, making sure that people are wide awake and together in that first hour of work. But these were all very interesting papers that we were able to publish based on these data sets, and no one had done this before for this population or had access to this type of data in mining. Thank you for that, Lee. I want to just mention another area of research that we've been engaged in that I think has also influenced policy in the United States and is influencing policy right now. I mentioned that things are getting worse, at least when we looked at that Kirsten's mortality paper, but we had other signs that things are getting worse when we look at the prevalence of lung disease by chest X-ray in this population. A lot of miners go and get a chest X-ray every 3 to 5 years, and if they have signs of disease, they have a right to go to a lower dust job. But when we look at the number of people with 25 years of tenure, this is the black line, that have a positive X-ray, it was going down. We're doing great until the end of the 20th century. And then all of a sudden, the rates of disease increased. And it really increased for almost every tenure level. In central Appalachia, that's Virginia, West Virginia, and Kentucky, it was a lot worse. And if you look at the people with 25 years of tenure, 1 in 5 miners in the most recent years that this data was analyzed had black lung disease, had evidence on their chest X-ray of scars in their lungs caused by inhaling too much toxic coal mine dust. And then the rest of the US, it wasn't as severe, but you can also see that it's increasing. So this is evidence just based on chest X-ray imaging that there's a problem with people getting worsening disease, that conditions, whether it's the mechanization, lack of enforcement, there's a whole bunch of theories about why it's happening, but we have surveillance data on a population nationally that shows that things aren't great. And then we also looked at how severe the disease was by looking at their X-ray that they had a few years ago and their current X-ray. And some of these people went from not too bad to really bad in a very short period of time. And these diseases are relatively slow moving diseases. And when you see that somebody's scar tissue is progressing very rapidly, that's a real problem. And we call that rapidly progressive pneumoconiosis. So if somebody got worse within 5 years, their X-ray progressed, that's pretty concerning because you usually expect it to take place if they're going to get worse, maybe 10 years, 15 years, but in shorter periods of time, that was a concern. And we were able to look at where in the country, this is work by NIOSH, where this rapidly progressive disease was occurring. And you can see here, the orange and red blocks indicate that this is the western part of Virginia, the little tail here. This is all the state of West Virginia and eastern Kentucky. So very severe disease was there. And then we looked at the rates of this horrible form of the disease called PMF. It stands for progressive massive fibrosis. And those rates in the active mining population also kind of nicely went down after the passage of the Coal Mine Act in the 70s, again to the late 20th century, and then those rates skyrocketed. We're seeing disease that I only read about in Emile Zola's book, Germinal. I wouldn't think that I'd be seeing it in my lifetime, yet we're seeing it not only in my lifetime, but it's increasing and getting worse in America. So it was really concerned. And then we found that in our Black lung clinics, there were large numbers of people showing up in these clinics with these massive lesions in their lungs from this progressive massive fibrosis, very severe disease. So we decided that, well, the active mining population is getting worse, but it was only a couple hundred cases. And a few people are showing up in these clinics, also a couple hundred cases. We wanted to see what was going on in the entire country. So luckily, we had access to this Department of Labor database on anyone that's ever applied for Black lung benefits. And we analyzed it to see what was the rate of progressive massive fibrosis, the severe form of the disease in the entire United States. And this is Kirsten's seminal work published in 2018. And we saw that that PMF was really increasing in the former miners in a very scary way. This is a graph from that paper, and you can see back in the early part of the when the Black lung legislation was first passed, there was a big spike when people were first able to apply for Black lung, and we saw a lot of people had this very severe form of the disease. But the proportion of people with this PMF, this very severe form of the disease, has been increasing really since the 1990s, and 96 maybe is the inflection point. And we're seeing a very, very large increase in people showing up for compensation in the Black lung clinics program with this very advanced, very severe disease. And so this is really of great concern. And it covers the former miners who had never been analyzed before. And it's really an interesting thing that this Department of Labor data set, this Black lung benefits data set, was never analyzed, had never become part of an epidemiologic study until we wrested that data out of their hands and got them to give it to us. And then we were able to analyze it and do that. And we actually were able to get an ongoing agreement between NIOSH and the Department of Labor to continually do this, to make this database accessible for public health purposes. And we also got them to change their database and to put in important data that would be more helpful from a public health point of view. So one of our little specialties has been taking these administrative data sets that are used to, administer compensation, insurance, whatever, and turn them into something that might be useful for public health. And so when Kirsten plotted this, you can see that the proportion of cases that had PMF of those that were applying for Black lung benefits also was very severe in Central Appalachia, these 3 orange states. And so we can see that we have a real problem in this part of the country where people are developing very, very severe disease, and that's a huge problem. So that made us try to figure out if we could figure out why this is happening, and we could help understand why it's happening and see if we could think of something that we could do about it. One of the thoughts is that people in mining in Central Appalachia are exposed to more silica. When you work in a coal mine, you get exposed to coal dust, that black carbonaceous material. But when you cut up rock, rock has quartz, and in that quartz it's silica, silicon dioxide crystals. We call it respirable crystalline silica, and that stuff is nasty. It's 20 times more toxic than coal dust. It causes scarring, it causes obstructive lung disease, it causes emphysema, and we think that that may be playing a role. We saw some signs on x-rays of patterns that were consistent with silica, but we didn't know for sure. And we think that what happened is that the big thick mines with lots of coal were being mined out, and there's small narrow seam mines that have a lot of rock above and below the coal. You know, if you think of a coal mine as a bologna sandwich, you've got the bologna, which is the coal, and you want to get that, and the bread above and below is rock. And if you take too much of that, you're going to get a lot of silica. In the old days, that was so hard that the miners just focused on getting that coal out because it was softer. But with modern mechanical equipment that's very powerful, they can chew through that rock like butter, and they create a lot of silica dust as they get more coal out. And we thought that silica was playing a role. And these guys, they're drilling into this is the guys that drill into the top and bolt it so that the rock doesn't fall down on them. They get a lot of silica there. And then if you look here, see if this works. Maybe not. You can see that this machine is cutting this much rock, and then below it is coal. And they're trying to put some water on that to keep the dust down, but there's a lot of silica in these mines. So that's what we thought was going on. So we decided to add to our X-ray studies and our lung function studies to look at lung tissue. If we could get a hold of lung tissue, maybe we could see what was happening in the lungs of these folks that were getting very severe disease. And we published this first. We got a case series of 13 of these folks that had died of very severe black lung. And we looked at their lung pathology, and we saw that even though it looks very black, this is an explant from a guy that went on to lung transplant from black lung. And it looks very black and looks like it would all just be coal dust. But in fact, there's a lot of this pink scar tissue in his lungs, these big round nodules of scar that's whirled in circles. And that's what we see with silicosis. That silica dust, that quartz dust, causes an exuberant response of scar tissue around it. And so we really thought that this isn't just coal, there's a lot of silica in there, but this was only a case series of a few miners, 13 miners. And here, this is called polarizing light microscopy. When you shine polarized light through lung tissue, if it reflects the light, it means that there's a birefringent crystal. And these crystals, it looks like a starry night, that's all mineral particulate that's permanently deposited in the lungs of that miner who had a lung transplant. So that evidence was sort of a sign. So Leonard led this next study where, because we work at NIOSH, they have an autopsy program where they collected lung tissue from miners' autopsies from the 1970s through the present, but really mainly active through the late 1990s. And we went back and we looked at that lung tissue to try to see if things had been changing in the pattern of lung disease in miners that had gone to autopsy in NIOSH's National Coal Workers Autopsy Study. And we looked at people who were born before 1930 compared to the lung tissue of people that worked after 1930. And we classified their scar tissue as having a silica pattern where it was mostly those pink round scar tissues, or was it black coal kind of scar tissue? And we found that there was an increase in that silica type of lung tissue changes in the pathology from autopsied coal miners over the decades, over history. And that in the recent cohorts of miners that were born, we're seeing a lot more silica-related lung disease in their lung tissue. And I had never really thought of pathology as an epidemiologic tool. People don't like to donate their lungs and participate in those kind of studies. But if you can find a way to get access to lung tissue and look at it, it can be really very, very helpful. And so we saw this. So this was an interesting finding, and it kind of stimulated us to do a much more careful study where we would look at the lung tissue in miners that were contemporary, people that were mining in more recent years under these modern mechanical mining conditions compared to these historical cohorts of miners. And we did this in a very careful, controlled way where we obtained the tissue, we got historical cases, and we got modern cases. And we had pathologists from South Africa, Canada, New York, Denver, and looking at this tissue in a blinded way, scanning their slides and classifying it to try to see if there had been changes in the pathological findings of the lung tissue in coal miners who had mined in earlier years versus those who mine now, and see if we could really prove what our case series showed us. We just did cases and showed they had silica, but is that something new? Was it just a strange selection? We wanted to look at a much more carefully selected cohort. And obviously we collaborated with our colleagues at the Respiratory Health Division down at NIOSH. And so we had these pathologists. This was all done during the pandemic. So we realized how wonderful virtual pathology could be. We had all our meetings on Zoom, and we were able to share images and classify and discuss discordant findings. And we looked for features in the lung pathology that indicated silica exposure. So the pattern of tissue changes, the way the scars look, makes you think that it's silica versus coal, or a lot more silica there. So we took a look at that, and we found how many of you are pathologists in here? Not too many. Okay, so I'll just go through this very gently. But we looked at the same thing that Leonard looked at, this PMF type. We looked at the silica type, mixed type, and coal type, and we found a significant increase in the percentage of silica type. 57% of our contemporary miners had that silica pattern compared to only 18% in historical. And that was true also in Central Appalachia. And we found fewer coal macules, fewer coal type scars. So they were having less exposure to just that pure coal dust in their lungs. And we actually found a very interesting thing. This is something called mineral dust alveolar proteinosis, which is a sort of an esoteric pathological finding, but alveolar proteinosis, where a bunch of proteins weep into the lung tissue when they're stimulated by silica, is sort of characteristic of silica. And we've seen it mainly in something called acute silica proteinosis, where someone's working in a plant and they get massive exposure to silica flour or silica in other forms. But we saw this in the lung tissue miners. So we coined the term mineral dust alveolar proteinosis, and I think that that is now becoming a thing. And we found that that was much more common in the lung tissue of the modern miners compared to the historical miners. So these are all patterns of pathology that are consistent with heavy silica exposure. And this is something that we thought was getting close to a smoking gun. But because we didn't have the smoking gun, we decided to get the smoking gun. And by what we did in this case was to take that lung tissue, we looked at the pattern of scars, but we actually wanted to look at the minerals. Can we see the particulate in the lungs of these miners? Lungs are wonderful things. They're filters. They filter out all that dust and they keep it for centuries or decades. So we were absolutely able to take that lung tissue, put it under scanning electron microscopy, and then focus an electron beam on every particle and determine what it was. Is it silica, silicate? What was the elemental composition of that particle? And we did this with a subset of the patients that we were of the tissues that we had, because it's very expensive and incredibly time consuming. And you can see this is a scanning electron micrograph. This is a little bit of a zoomed up version. You can see macrophages here with a lot of engulfed or phagocytized particulate matter. And then if you take that and you shine an electron beam like on this guy here, or you shine an electron beam, you can see that this one is aluminum silica when you look at the peak of absorption of the X-ray energy. And this guy over here is pure silica. So we were able to look at these miners' lungs, and some poor pathologist, bless her heart, sat in front of that microscope for hours counting particles in these tissue samples. And lo and behold, we found that there was a greater percentage of particles that were silica in contemporary miners, and the particle concentration of silica was greater in the contemporary miners. And then we later went on and we looked at the pathological findings that we had seen, those patterns of scars, and counted the silica if the pattern was present or absent, and proved that those patterns truly did reflect increased silica concentration. So we think that this is the smoking gun that shows that contemporary miners with worse disease, worse mortality, and worse lung function, that silica is certainly increasing and perhaps playing a role. And so this paper was published, and MSHA, the Mine Safety Health Administration, which is like OSHA for everybody in mining. OSHA doesn't regulate mining, it only regulates us, every other job in the country. They're developing a new standard because the standard for silica is old and horrible. It's worse than the OSHA standard, which is 50 micrograms, and that was changed in 2014. But it was never changed for miners. So if you're mining and exposed to silica, there's no protection for you. But if you're in construction, it's better protection. I shouldn't say no protection, but the rules were very different. And so MSHA has now got a proposed regulation, and they've cited this study and a lot of our work in their rationale for why this needs to be changed. So it's kind of fun to be able to influence policy. So that's some of our research. We did another study that involved the pathology, which was a sadder sort of a study. This is a mine disaster that took place in 2010 in Upper Big Branch Mine in West Virginia. 29 miners were killed instantly by this explosion and by the carbon monoxide that was a result of that explosion. I was part of the committee that was investigating it for the governor of West Virginia, who was Governor Manchin at that time, now Senator Manchin. We found that in the miners that died, even if this was a pretty nasty mine, pretty poor conditions, probably why it blew up as well. We found that even relatively shorter tenure miners had black lung, had changes in their lungs, because all their lungs went to the medical examiner. We were able to get those reports and review them, and then we were able to get tissues. And so recently we just published the data from that disaster. Leonard took the lead on this paper, and we looked at their pathology, but Leonard, working very carefully, looking at the dust levels, showed that the dust levels in this nasty, horrible mine that blew up weren't that different than many other mines. In other words, it wasn't just like one single horrible bad mine, but that there were 200 mines in the US that had higher concentrations. So it was a very interesting paper because he looked at the pathology, we looked at what that was significant enough to cause black lung, and we looked at the dust levels in that mine compared to other mines, and showed that likely these mines in the rest of the country are quite sick and are producing a fair amount of disease. And we've also known that because of our X-ray studies and our compensation studies, but I thought this was a really nice study that Leonard led and put together. So that's most of our work in the US, but I would like to say that we've been working in other countries because this population, which is just a wonderful population to work with, they're the salt of the earth, these folk. And we've done work in Ukraine. I'll show you a few pictures from that. That was actually my first work that I ever really did deeply with UIC. I was still at Cook County Hospital at that time, and Dan Rahorchik in the Great Lakes Center, those of you that know Dan, and Lorraine Conway was actually part of this work. She did some industrial hygiene work in Ukraine with us, but we went there to try to assist them in their medical surveillance and also how they took care of people. So I'll talk about that, and then we'll talk about some of the work that we've done in Australia as well. So with the Great Lakes Center and with the Fogarty Center of USAID and NIH, we went to Ukraine and we're working in Donetsk. Does anyone know where Donetsk is? You've been following the war in Ukraine, but it's in the Donbass, the southeastern part of Ukraine. It's all Russian controlled right now, since 2014, actually, when the Russian paramilitaries went there. But we were there before that, and the idea was to build our capacity in medical surveillance, which is really something that we've reproduced. This was our first effort at this, but it really laid the pattern for us to do this work in other countries. And Judith Graber was a epi student here at UIC, and she published on this and had the opportunity to work with this data. Just to show you some pictures, these mines were built at the turn of the previous century, and they were still active at the time that we saw them. You can see these are low, very deep mines. They're 1,500 meters underground, which is really deep. You ride an elevator down a mine for 10 minutes before you get to the bottom of the mine. So we went, visited them, worked with the miners. These are the docs in the clinic there in hospital number 25 in Donetsk. These are some other pictures. That's me hiding behind, this guy here is the Secretary of Labor for MSHA under Obama. But you can see that these folks are pretty heavily exposed in these deep mines. This is my favorite picture, that this gentleman was working for 8 hours at the tailgate of a longwall. That means the air goes all along this coal face, and he's working at the end of that. So he was fairly covered with dust, and you can imagine what his lungs might look like after a few years working like that. And we also visited a mine that had just exploded in Ukraine 2 weeks before, killing over 100 miners. It's the Barakova mine, right on, well, that was the Russian border, but that border has now changed. So that was an interesting, this is the list of the miners that all died. This was March of 2000 when we were there. Anyway, it was our first opportunity to really assist. And we did that, we repeated this work in Australia recently. Our group has done a huge amount of work working with the Aussies on coal mine dust lung diseases in that country. Most of our work has been in Queensland, but recently we've just finished a large review of the surveillance work in New South Wales, which is really this area. It's a beautiful area of Australia. It's got coal mining and wine production. So two of my favorite things in one area. So I think I'll retire to the Hunter Valley of New South Wales. Great Shiraz. All right. The Aussies thought they'd gotten rid of black lung. And this is published, oh, I can't remember. Leonard, do you remember what year this was published? 2004. So the Aussies said, we have no black lung. They had 30,000 miners working every day and not one case of black lung. And really what they had eliminated was their surveillance. So there's two ways to get rid of the disease. You can get rid of the disease, or you just get rid of surveillance. And if you don't find it, then it's maybe gone.
That's how we got rid of COVID.
What's that?
We got rid of COVID to save.
Right, exactly. You can do that. The ID physicians have an old saying that says, if you don't take a temperature, you won't find a fever, which is true. And that was usually lazy medical students who didn't want to have to go and do all the workup of the febrile patients in the hospital. So they had reviewed this program. They said it was not a problem. They just had a fitness for work program. They weren't reading their x-rays. They weren't capturing data. And then what happened is that the head of the coal mine workers union down there came to Las Vegas to the US mine workers meeting and brought x-rays of all these miners that were diagnosed with a disease called sarcoidosis, which is a rare disease that's idiopathic. We don't know what causes it. Now, why would you get 10, 15 coal miners all of a sudden developing this rare disease? And they showed us the x-rays when we were speaking at that conference, and we said that this is not sarcoidosis. This looks very much like black lung. And they actually went back and biopsied these guys, because we never usually biopsy people for black lung, but because they had eliminated black lung, we asked them, they got biopsies and proved that it was coal workers pneumoconiosis. And then sort of the dust hit the fan at that point. I made the front page of the paper in Mackay, which is in Queensland. What went wrong? That was what went wrong with their system. My parents have wondered that for years. But essentially, there was an investigation where that the union, the industry, the government, the Thoracic Society, the radio, they all screwed up on this. They all completely dropped the ball and had eliminated their surveillance program. And it hit the ABC News there and was a big issue. So we decided to take our crack team of University of Illinois investigators, pictured here in Australia after having visited underground, to go and try and investigate this problem and see what we could find. And we worked and testified for the Queensland parliamentary investigation on this that happened after we showed them that they had black lung. I love this report because the inside of the report says a quote from a coal miner that says, "Black lung has buggered my life." Now, we would not print something like that probably in a US Senate investigation, but that's what they said there. But and then it was a federal investigation as well, where they basically said that they had dropped the ball. There was a lot of pressure on them to revamp their surveillance program. And we worked there ever since. This was 2016. We've been working there for the last, good 6-7 years. In the process, we classified 65,000 x-rays for them until they retrained their radiologists how to review x-rays. We developed, and Leonard did a lot of this work on managing training for all their occupational medicine docs and radiologists on how to evaluate miners and standardized programs for that. And then we've been consulting very closely with the Australian Office of Industrial Relations, their main compensation board, and their Respiratory Safety and Health Queensland, which is the regulator for these diseases there, and worked with them to develop policies on how to get people with early disease back to work, when is it safe, pathways for the docs to evaluate black lung, compensation policies. I remember Leonard and Kirsten and I were sitting in a room deciding how much money they should get, and we gave our suggestion. The next thing we knew, it was published in their regulatory framework. And they actually said that they have to have experts, and they mentioned experts like the people from University of Illinois in Chicago in their legislation, which was quite nice. And so then we were able to after that, we were asked by the New South Wales government, the state that's below Queensland, to do the same thing. And we've just finished that review, and maybe Leonard will give a talk on that at some point on what happened in New South Wales. And also, very nicely, we were given a grant by the government of Queensland to do our data linkage sort of activity, where we're going to take data sets from their surveillance group, from their workers' comp group, from their self-insured and their uninsured government compensation groups, as well as looking at their dust data and try to understand the prevalence and severity of Black lung in this population over there. And that grant is enormously complicated only because the Queensland government, the University of Queensland, and us have to have their lawyers agree on a contract. I was reminded of this when Sam was talking about all of the different government agencies that they were working with and how hard it is to do that. So these are the groups of folks that we've collaborated with over the years in the UIC Minor Center, which has really been, I think, one of the most fun things about this work is working with really good, caring people all over the world and in academic centers as well all over the world. We've made some wonderful friends in this process. It's been a great collaboration between the unions that represent these folks, government agencies, and we work well with industry as well. And it's a really tough thing because these are somewhat adversarial relationships. And so balancing, the interests of industry, the interests of the miners, the regulator has been very difficult. And Leonard and I are waiting to see, we've just handed in our report on New South Wales. We have to then undergo interrogation by those stakeholders at some point about what we thought. So I'll stop here. This is a picture from Ukraine. This is a man is inserting metal chips into a machine. When you go to the mines in Ukraine, you have a metal chip that stays on the surface and a metal chip that goes with you underground. And the machine they put those chips together at the end of each day. And they have a toast. They'll drink vodka at the end of the day and say, "May your two chips always meet." Which means you get the hell out of there, alive. But we also want to extend that to say that we want you to come out of your career. Our goal as occupational medicine and public health folks is that people should be able to work an entire career in an industry and come out healthy, and not just each day, but at the end of your life, so you can lift up your grandkids and, be able to function. So I'll stop there and see if there are any questions. Or if anybody wants to work with us too, yes.
Interested if you could share at least your experience, at least like with good research, how you have changed your experience in doing it in Australia and internationally, and then your experience in the US, advocating for policy action, stuff like that.
It's interesting. It's funny because our first project in Ukraine, it was part of what was called the Kuchma-Gore agreement. President Kuchma of Ukraine and Al Gore, they had an agreement to provide capacity. But the AMSHA guys told us that the kind of work that we were doing there could never be done here because there was so much opposition from the US coal industry that it was really tough. And it depended, that was, by the time we went there was, under the Bush administration. So it just depends on who's there. So it can be very difficult. The Aussies have been great to work with. It was, so it really varies by country. And in this country, we've been able to do stuff. We were testifying before Congress for this new silica rule a couple of years ago, and under the Trump administration, we weren't as successful. Now under Biden, there's a really pretty good guy who's head of AMSHA, and they've been much more open to this. But we're very aware of the politics, and in Australia, we watch the elections carefully to see, is it going to be Labor, is it going to be Liberal Party, which, or what's going on, because it makes a difference in terms of the regulatory climate, as you probably can imagine. Yeah, Colombia was scary when we were working down there, but the government there was not as open to some of this.
With advancements in technology with energy storage, first cobalt mine, where I don't know, lithium mine in the battle. What are we doing to proactively protect workers and currently from exposures as opposed to reactive?
Yeah, that's it's interesting because those mines there's no federal program for what they call metal non-metal mining. So whether you're mining for potash or copper or gold or lithium or anything, there's no standard surveillance. So they just have recommendations, and it's they're going to be exposed to silica. Most likely is going to be the main toxin, which is a very dangerous toxin, as we mentioned. So there, I think we'd be great if we could advocate for that. There was an attempt by NIOSH to have a van that went around the country for metal, non-metal mines, especially out west. But the senators from the various states got together and it was squashed. It's something that we have to fight. They're also not in one big union like the coal miners were. And that's another problem. So if they're unorganized workforce, it's harder to get pressure to get these things done. Fracking, I think, is another huge silica exposure that we just don't know enough about the populations that are exposed. But that's a great question. Unfortunately, there'll be work for our group going forward. Yes.
You mentioned that a lot of times workers will not need surveillance, like partake in surveillance programs and everything. How, and your team's been part of this, if you know of any teams that are looking towards, like getting employers to understand that good health is good production and that you want your workers to be surveilled so that they can be productive and everything. Like, how are you guys doing that, making sure that surveillance is?
Well, NIOSH has an advanced team that goes out and talks to the employers. Some of the employers are much better citizens and they'll even allow the van on their work site. Others are absolutely against it. They're afraid that if people get surveyed and they have disease, they'll get workers' comp claims. And so they can be very difficult. If you guys have ever watched John Oliver on TV, anybody know John Oliver? That comedy news show, but there's a section he did on Murray, Bill Murray, who was the owner of was he I think Utah, he was out in Utah. But anyway, watch that segment and it talks a little bit about the coal mine industry. But there's some good actors and we've worked with some really good companies and they're different in different countries. Like in Australia, they're nicer to work with than the same company in Colombia. So we actually had I think it was BHP that had a mine in Colombia that we were working in, and they were real nice to us in Australia. They weren't so friendly in Colombia. But
Sorry, that's Bob Murray, you guys. We have
what's that?
Bob Murray, not Bill.
Bob Murray, yeah. Bill Murray is Groundhog Day, right? Yeah, okay.
Getting, more into injury and illness and stuff. So I know like the opioid epidemic has been huge. You haven't watched Dope Sick. Anyone in your need to read it. Are you guys transitioning at all into that?
Maybe Kirsten will give a talk on Kirsten and Tessa.
To have a new grant to look at that.
That plot I showed you of pneumoconiosis in Central App, if you look at opioid deaths, we plot it's superimposed on that same, it's perfectly superimposed. Yeah, but we have a whole, that's a great thing. No, we're doing a mental health in our Black.
Health, I was wondering, like,
Yeah. Yes, sir.